Welcome to CDM, our very last class. And I'm so sad I can't be with you, but this is the next best thing, is pretend you're with me. I just had a few things that I wanted to go over with you before I let you loose. And so you might just want to jot down some of the data, and then I have a few little demonstration things. It's just something to kind of remember that when people are on the thyroid, synthroid, that they should not take soy products. And I can't tell you why. It's just everything I read says it's some interference with the effectiveness of synthroid if people have very much soy. It may be that it takes a lot, and so it doesn't matter. And then I just wanted to emphasize so much to you, the washing of hands, and to let your patients see you washing hands. And when you enter a room, go in and at least turn on the water and make them think you're washing them if you just got through washing them and you hate to wash them again. But patients have a lot of confidence if they think you're very conscientious about washing your hands. It came up in the IV lab that people were a little confused that piggyback and secondary were two different items, and they're not. A piggyback IV is the same thing as a secondary, and it goes into the main line above the pump. Now, if you have something joining below the pump, unless that's joining below the pump is free will, gravity, it probably is in a pump of its own. And it's really not called secondary. If it has a pump of its very own, it's just another main medicine or a main infusion. So piggyback and secondary go into the main line above the pump. Anything you add gravity, you would put it in below the pump. But if that second line needs to be pumped at a certain time and pace, then you would have it in another pump, and so you have two pumps, like down in the unit sometimes you did. Guaiac, G-U-I-A-C, I told you means hidden, and I mentioned that at the last class, and somebody came up and asked me if that could be for urine or for anything, and it can be for gastric, it can be for pleura, it can be for fecal. Guaiac means hidden, and it indicates hidden blood if they're looking for guaiac. Then I wanted to talk to you about the TED hose, and I mentioned them here and there, but I really wanted to go over what I want you to remember about the TED hose, and that's where I wasn't sure how good I did a job on that before the midterm, so I wanted to do it now. When you walk, and I may have already told you this, so just tune me out, but when you walk, your muscles are squeezing your veins and exercising your veins. And that's a great thing. That's why it's great to walk, because it's massaging your veins. When you are lying in bedridden, that isn't happening, and those veins become flaccid. They are supposed to be exercised all the time, and so they become flaccid, and that's why it's so easy for blood going through veins that aren't being active to start collecting and have a clot. So somebody scientifically discovered that we could put hose on and take them off, put them on and take them off. And if we do that once every 8 hours, that's enough. So your bedridden patient or your post-op patient just needs those TED hose taken off once every 8 hours. And of course, sometimes they don't get taken off till the next morning. You're in a bath. But you always take off TED hose to give a bath, because that's what you're doing, is massaging the veins. So bedridden, you can just take off the hose, wash their leg, put them back on, and you have done that massage. And as I said, for normal, healthy people, one of those times every 8 hours is enough. Now, if you are getting up and it's first day post-op and you put weight on the legs, that's doing a much better job than what the hose were doing. So if somebody stands weight bearing and sits down in a chair, then go on and wash their legs. Take the hose off and wash their legs. The big thing is don't put the hose back on until they're back in bed for at least 5, 10. Somebody told me the other day it really doesn't do any good unless it's about 15 to 30 minutes for the blood to get back up into the, out of pooling of the legs. I'm happy if you can just get legs elevated for 10 or 15, 5, 10, 15, just a little while. 5 minutes is okay for me. But keep watching, because I did hear that they are saying we need longer to have people on the bed before you put the hose back on. Because when you put the hose back on, if they've been sitting, it's squeezing pooled blood that has collected in the lower extremity, and then you put that tight elastic on it, and that's not so good for it. It's better if it's been drained, the pooling has been drained. Now, if they're walking, they don't even need the hose, and they really don't need the hose once they're weight bearing. So technically, as soon as they put their weight on their legs, they don't need the hose because it's doing a better job than once every 8 hours doing this. However, people still wear them, and that's all right if they want to wear them, but I just want you to be and know when it's doing good and when it isn't doing good. So, the best case scenario is when a patient is bedridden, take them off, wash their legs, put them back on. If they're weight bearing and just kind of scooting over to a chair, then take them off, bathe their legs, and don't put them back on till they've been in bed 5, 15, an hour, whatever, in time for blood to get out of the legs from pooling because they've been lower than the heart. If person is walking, they don't even need them, but a lot of patients have just been emphasized to that they need to wear those hose, so don't get in an argument. Just let them wear them. And I always say they're anti-embolotic when a patient's in bed. They are just support hose if the patient wants to keep them for a while and wear them walking around. Just call them support hose. In 2 weeks, they have served their purpose, and I call them socks. So after 2 weeks, they're really socks, and that isn't my idea. I talked to a woman at a medical supply house because she told me that TED hose are worthless after 2 weeks. And so I asked her, if we wash them and pat them dry with a towel, can I put them in the bathroom and the patient use them, have 2 pair and alternate? And she said, you can do that all you want to, but the elastic is gone for what it was supposed to have meant to do. So they're anti-embolotic when they're in bed, they're support hose if they're walking, they're socks after 2 weeks. Now what about the sequential compression? Somebody got an idea, let's wrap this sequential compression sleeve around legs and then let them periodically be massaging. Great idea. A, they're hot. B, they're expensive. And there's no real scientific proof that it's any better than just at the foot of the bed asking the patient to push their feet up against your hands. Just push against me. There's just no scientific evidence. It's a great idea, but they're an expensive apparatus, and patients, a lot of times they're just in the floor. But the idea is massaging veins, and I wanted you to know that. And I've kind of beat that to death, but I do believe in them. And a lot of times when I'm with the student, we're putting the patient back to bed after we've kind of washed their legs or they've gone to the bathroom and we put their feet in water. Then we'll put them in bed and they'll say, you forgot to put the hose on. And I'll say, now let me tell you something. I want all that blood to get out of the legs, back up into the legs. And so I want them to lay like this about 10 or 15 minutes. If I don't come back in, so I'll pull out my worksheet, in 15 minutes, right, come back to this room. But if I tell them, if I don't come back, stick your head out and motion for me, and I'll come back, put them back on. They're very willing when they understand, but a lot of times they remind you, you didn't put the hose back on, or the sequentials. So I want you to teach a little there. Wanted to mention salt, and I don't think I have, maybe have, but if you don't salt anything, you'll probably get about a teaspoon of salt a day. And that's 2,000 milligrams or 2 grams sodium. And you know, you're told 2 grams sodium diet. Well, that's what it is. It's a teaspoon of salt, but we get it in our canned foods and our chips and other things. We get way more than that. And if you'll take the product and turn the label where you were looking for carbs for me, or servings and total carbs, look at sodium and know that our whole day's supply should be 2,000. And, you know, 1 cup of Campbell's soup, I think, is just about that. So watch that, and when you teach your patients about sodium, just tell them never pick up. The idea is to never pick up a salt shaker if you're on a 2 gram sodium. Don't cook with it. Eat as little of it as you can, knowing that you're still getting a lot of salt. You get it in frozen foods and canned foods, and hardly anything is packaged that doesn't have a little salt for preserving. Now, while I'm on milligrams and grams and all, sometimes Tylenol and aspirin will be ordered as grains. And I just want to make sure you know that 60 milligrams is 1 grain. So, what's a Tylenol? 1 is 325 milligrams. And so, 60 into 325 is about 5. You have a little extra for overage. But a 5 grain Tylenol or 5 grain aspirin is 325. 10 grains is 650. And I just want you to know that 60 milligrams is 1 grain, and then 5 is 300, almost. It's 300, but they allow that 325 for a tablet. Just remember that a teaspoon's 5 milliliters, and I think that's good to always know anytime you're wondering, or you're wondering about measuring. Just keep that in mind. I mentioned last week, I want you to analyze, measure. You look at mucus or vomit or feces, and you don't have to package it up and put it in something. You can kind of look, would it fit, as I told you last week, a 1 milliliter syringe, a 3 milliliter syringe, a 30 milliliter medicine cup, a 240 coffee cup, a 120 juice cup, or a quart, which is 1,000 milliliters. I don't see this in your briefs, and I don't know why, and maybe it is in there. I just kind of thumbed through tonight to see if I could find it. But I want you to keep in mind D, D, D. Don't do dextrose and dilantin. In other words, if I had dextrose, D5W, flowing as my main line, and I had to give dilantin IV piggyback, they will clot, like, or clabber, like they'll look like buttermilk. But sometimes things don't, sometimes they react and they don't, it's not visual. You don't see it turning white. But I just want you to always remember that don't do dextrose and dilantin, DDD, because it can catch you sometimes, and then you have to throw away all your apparatus and start all over. And a lot of times the pharmacy doesn't label dilantin, only give dilantin with normal saline. And then we have amphotericin B, and I want to see, I think that is in your medication. But dextrose has one that it has only to be used with, and that's amphotericin B. So amphotericin B, as I said on page 16, for fungal, it can only be given with D5W. So keep that in mind. Amphotericin B has some other qualities. It is photosensitive, sensitive to light, and then a patient needs to, the things are listed right there on page 16. There are 2 other newer drugs for fungal, for fungus, and that's Abicet and Abasone. And these drugs decrease potassium, so you'd want to watch that. And then you'll see it says mix with D5W only, and they're photosensitive. They are, especially amphotericin B is very hard on the nephrons, the kidneys. So before a patient gets amphotericin B, they flush them with normal saline or some kind of fluid to just really flush them good before they give them amphotericin B so it won't burn their nephrons. So I wanted you to keep that in mind. Calcium, I think we've already mentioned it, just want to mention it again. I think we mentioned it when we mentioned nutrition, but a serving of calcium, milk, a serving of milk is 300 milligrams, and our body can only handle 500 in 5 hours. And I think I talked to you about premenopausal and menopausal. And I know I did because there was a quiz on it. But just to remind you, menopausal women, 1,200 milligrams. Postmenopausal, 1,500 milligrams. But you can do it in 300 milligram servings, or take some kind of calcium tablet that equals that. I just wanted you to remember the roots of drugs and how we give them and what is fastest. And I think, and I hadn't necessarily seen it listed, but I think the fastest that a drug can get to you is probably sublingual. You put it in your mouth and it is into your system in no time. I think you learned that too. That'd probably be the fastest. IV's awfully close. So sublingual, IV, oral, sub-Q. Remember, sub-Q is not real fast because it's in the tissue. And then IM, and then probably intradermal next. So keep that in mind on how fast drugs are absorbed in our bodies. Sublingual, IV, oral, sub-Q, IM, intradermal. And interfecal in the rectum is pretty fast, and it'd probably be right after oral, probably, the interfecal. Which brings up, and I don't know whether you've heard of them, you know I don't go for slang terms, but they call it the poop pill. It's a transplant using fecal material. And I don't know whether you've heard of it or not. It's being done in Nashville. It had been done on my floor. But a friend of mine talked to a physician here in Nashville, and he says he does it when somebody has C. diff and their GI system is so torn up, so inflamed, in such terrible shape. They're cramping. 15 and 20 defecations a day. They need some help, and nothing is stopping it. And so here, the doctor in this city says he just takes fecal material from a family member, and I guess he treats it in some way, and then paints the rectum. That can be done that way. The way I read is that a family member donates their fecal material, and it is taken the bacteria is cleaned, the food's taken out of the feces, the bacteria is cleaned, and then it's put in gelatinous capsules, just stuffed in capsules. And the person will take 24 to 27 capsules several times for a couple of days or whatever. And they have great stats on that their C. diff. They give, I read a statistic that of about 20-something C. diff patients, they didn't have any that had returned C. diff. Let me see if I can describe 27 patients who were treated this way on a Thursday, and they had suffered at least 4 C. diff infections and relapses, but none had a recurrence after taking the poop pill. So, you heard it here first that there is, they call it fecal transplant. So, you've heard of it, and I'm glad you have. Another thing that's new out, and some of you may have used them, is the bladder scanner. Rather than not sure if somebody's bladder's full, and catheterize them to find out and introduce germs, because I'm going to tell you there's no way, as sterile as you are, that you're not going to introduce some bacteria into a bladder. And so they have these scanners that can scan the top of the bladder just on the outside and can see if you have a full bladder or not. And some of you, I've already told you more than I know. That's just what I hear. I'm told about that. I want you to remember Ofirma, Ofirma, O-F-I-R-M-I-M-E-R, Ofirma, which is the IV Tylenol, and that's in the medication part of your briefs. Ofirma, Ofirma, or something like that. Look it up. But it is IV Tylenol. They say it works better than some of the narcotics. And it is used in Nashville some. The IV ibuprofen is Caldolor, C-A-L-D-E-L-O-R. It's also in your medications, C-A-L-D-E-L-O-R, IV ibuprofen. Just keep in mind, the granddaddy of all anticoagulants was Coumadin or warfarin. And then they went to Pradaxa. And I have people, I don't know why, Pradaxa seems okay, but people think it's just horrible. And you don't have to have your blood checked as often, but people who really work with people in DVTs aren't as proud of it as I would think they would be. Xarelto, X-A-R-E-L-T-O. X-A-R-E-L-T-O, Xarelto, is another anticoagulant that you will be using. I just wanted to make one comment on names of patients. We had a patient who had a difficult looking name, and so the student called her Miss whatever, first name, Miss Jane. Showed her respect, but just didn't even try her last name. And the floor didn't either. Everybody on the floor didn't either. And I told the student, I said, let's try to learn her name. To me, that shows so much more interest and care. If you care enough to ask somebody's name and how to pronounce it. I want to know how to pronounce your name. When the student worked with the patient, it was so simple because it was phonetically just each syllable. And it was such an easy name to learn. And I thought how many times people have not even tried her name because it looks so long and hard. So think about that. And are you just calling them Miss Jane because it's easier? Or do you care enough to try to learn a little more about their name? It happened to us, the students and I share it with you so you won't do it and be so conscious because it reminded us. Late in the day, we were asked if we wanted to start an IV or fix up the tubing for a patient, and we said we did. And so it wasn't our patient. We're kind of task-oriented, and so one or two of us went in the room, and she had a visitor, and the woman was from a nursing home, very contorted, eyes almost rolled back in her head, her tongue kind of sticking out. And we assessed right then that this woman wasn't with us. And it's just because of the way she looked. And so we went in and started working and really didn't speak. I'm not sure that we even spoke. We were just so task-oriented. And then we saw the woman herself, and we were just a quick job, just hang her tubing. And so at some point the visitor, in a very scolding voice, said, if you would tell her what you're doing, it would be nice. Bingo. We realized that wasn't a good thing to do. So the students, of course, they were jarred just like I was, because I didn't do any better than they did. And when we were getting ready to leave, the visitor called me over and said, do you not teach your students to speak to the patients? And I said, oh yes, we do. And that just got by me, and I apologize, and so sorry, and thank you for bringing it up. And I truly meant that, because it just reminded us, we just get so caught up in what we're doing that we forget. The student, not real sure the patient knew that much anyway, but the visitor scolded us, and it was okay. It was all right to do. Now, remember on stool, vomitus, gastric, possibly amount, color, and texture. Always never have anybody ask, wonder what that looked like, or wonder how much. You want a chart in such a way that no one would ever have to find you to say, tell me more about it. It doesn't even have to be long. Just give them color, consistency, amount on any of this that you look at. Be real careful about IV solutions. 0.225 is 1/4 saline. 0.225. And remember, 0.455 is 1/2 saline. So don't forget those words. And when I lectured on hematology and Desferol, Desferol, it was the drug, and it's in your medications, that takes iron out. DE, like take for dehydration, it's take water out. For Desferol, it's DE for sol, taking iron out. Now, remember, it's in your briefs, Troche. A Troche, T-R-O-C-H-E, is a lozenge. When you see the word Troche, T-R-O-C-H-E. Pre-albumin and albumin, I think I have already told you, but I wasn't sure. I was looking through your briefs, and it's something I think is important, that when somebody's checking albumin, and we know how important albumin is with the osmotic pressure and pulling fluids through membrane. And so it's more accurate for the here and now to do a pre-albumin, because the word is, as I said, I may have already told you, that if you do an albumin, the pre would have been two weeks earlier. The here and 1, 2 and 1, all go in a vein. I just want to make sure you know that. Remember that muscle mass at waist. If somebody's bedridden, their BUN may go up. Their waste in their serum may go up. Uric acid, urea, all those may go up. Pyridium, it's in your medications, page 20, I believe. I wrote that down, pyridium. Pyridium is a medication that helps only urinary tract pain or discomfort. It doesn't cure. And so it's palliative. Palliative helps make you feel better, but palliative isn't a cure. Palliative. And so Pyridium, Pyridium, is a palliative treatment for urinary tract. The self-intermittent catheterization on page 9 in your briefs, SIC, S-I-C, self-intermittent catheterization. And it's just that. Someone catheterizes themselves. And the stats or statistics show they have less bacteria entry than we who put a Foley in. And I don't know, but I'm just telling you, if somebody's at home and they're doing SIC, self-intermittent catheterization, they just have to be clean. And of course the catheter has to be clean. It doesn't have to be sterile. They usually will keep them in some betadine or something like that in the bathroom, and then they go in and just put it in their urethra. So SIC, S-I-C, and know that. Montgomery straps, I just can't remember if I've told you, and if I have, just skip or something. But I just need to remind you if I've already told you. Montgomery straps, you make them yourself if you want to, or you can order them. When somebody has a wound that has to be removed, and say 3 and 4 times a day, if they have tape, it's pretty hard on the skin. So somebody came up with the idea of take some tape and, here we go again, back to back. Sticky is facing you. So back to back and back to back. And then stick the sticky part, and then this isn't sticky. You put holes in it, and you can just open it, and the 4x4s just change them, or the ABDs just change, and then lace it up like a shoe lace. And they're called Montgomery straps. You can make them yourself as big or as little as you want to. Or as I said, you can buy them from the hospital has them in the supply area as well. But, you know, so a lot of times you can make them just as well. Now, Montgomery straps, let me see what. Iridia, I know you know what it is, Iridia, and it's in your brief medication as well. But Iridia, remember, is calcitonin. Iridia is calcitonin, or it will take calcium into the bone. Now, a few things I want to show you or talk about. And one is the Foley catheter, and I don't know whether you can see it, but of course you know that has the appendage that needs a syringe, not a needle, but to blow up the bulb. Anytime you see that kind of appendage without a cap that a syringe would fit, it probably is going to blow up a bulb. If I need to get a specimen, I just put a non-needle syringe on here and put a clamp this and put a rubber band around it and get fresh urine and put a syringe there in about 30 minutes and aspirate good fresh urine. Don't get it from the bag. And I know in fundamentals you learn that. I just have a need to tell you again. If you need to get a specimen, another type of way to do is this one, now this bag and urimeter. You might can get fresh urine from the urimeter. You might be able to get some fresh if you empty it and then get the next hour's urine. Or you can do our clamping, get fresh urine, and there is a little pad there that they do allow you to put a needle and aspirate. So just another way of getting the specimen. Now, I did want to show this portable sitz bath. If, especially you all that were in OB and any GYN surgery that might be in the perineal area, and warm water is good for circulation, and healing goes with circulation. And so it's an old, we still do it, but it's a method of healing that I think's lost some popularity because I'm not sure people thought it was that good, but warm area is good for healing. And so in the old days, people would get in a tub and run the warm water, just shallow, and that warm water, besides just cleansing, it caused blood to come to the area and start healing. Well, so many hospitals don't have tubs anymore. So you put this bowl on the commode, and this comes with it, kind of like an enema tubing. You put warm water in the bag, and then you see this little hole right here. So I'm putting the tubing in here. It fits in the bottom in that little wedge, and then this goes on the commode. This hangs up, and the person sits on the commode, and this fills up and overflows here into the commode, and they have that constant flushing of warm water. A portable sitz bath, S-I-T-Z. I wanted to say something about catheterization. You say, now listen, we've learned all that, and we did it in skills and all that. I just wanted to say, when you have your kit, I wanted you to see, you have your kit, and you have opened up your betadine or whatever, and put it on your cotton. See the cotton? You put it on your cotton. Of course, you're sterile. You've got your sterile gloves on. A nurse taught me, I learned from everybody just like you'll be always learning too. With her sterile hands, when she poured the betadine on her cotton, she took her fingers, with her sterile fingers, and broke up the cotton balls. Because have you ever seen anybody catheterize, and they pick up, these stick together, and they try to do this? Well, they can't take this hand because the hand's holding the labia open. And they have a time. I've seen people have a time. Well, if before you lose your hand to holding the labia or the penis, you would just separate them, then it's a great trick. I think it's a great trick. And while I'm on catheterization, let me talk about, you can never, ever catheterize that you don't see urine. You're going to always see urine, with the exception of a male. Women, you're always, when you open the labia and start in with your catheter, you don't come out till you see urine. You say, well, they're dehydrated, they haven't had, it's kind of like the story and the gastric secretions. You're always going to have a little gastric. You're going to always have a little urine. And I know one time I thought it was urine, but it was some of the KY on the tubing. And we blew up the bulb, and an hour later, no urine, and then we realized we were in the vagina. So make sure you really see urine, and then blow up your bulb. With a man, though, it's different. So when you hold the man's penis, and you're done all your preliminaries of wiping the head of the penis, and start putting the catheter in, you may go all the way to the end. I've done it where I'm catheterizing the man, and I go on in all the way. This is the head of the penis. I go all the way to here. Do you see? I can't go any further. Well, go on and blow the bulb. I ain't got urine. Go on and blow the bulb up, and it'll come on till the bulb hits the top of the bladder. I ain't got any urine. With a man, it's okay. There's only really one direction. If it went, it's probably right, unless he's climbing the wall and it's crooked and kinked. And they don't let you just lay, they don't lay there and let you do that. If it is crooked up, they're coming out of the bed. If he let that man let you go all the way to here, blow your bulb up, bring it out, and hang your bag up and come back in 20 minutes, I'll promise you have urine. Why? Because it spasmed, and probably his spasming squeezed down on the tube and won't let urine come out. So women always see urine. Men, if you didn't have any trouble catheterizing them, then go on and blow your bulb up and come back in an hour. I was working one night, and it was when they wouldn't let women do it, and a tech did it. But he came back and he said, I just can't get any. I've gone all the way to the top. And I told him, I said, you just blow up your bulb and you got it. So, just a little word. While I'm talking about catheterizing men, push, if you're cleaning and bathing a man and you've pushed the foreskin back, even if he's circumcised, there's a little bit of foreskin that might need cleaning around. Clean around, but if any foreskin, if you had to push any foreskin back and clean, make sure you bring the foreskin back to where it originally was. If you don't, the head of the penis swells, and then the foreskin is like a rubber band, and it's very painful. And you know, there's just no reason. I have been over to the hospital to make assignments, and there's a note saying, Dear doctor, please, the foreskin of the penis will not go back over. Let me tell you, it will. You may have to get some Vaseline or something and work the foreskin back over the head, but please do not say, well, I'll come back later. It's just going to swell, and it's putting him in pain. So I'm telling you, if it was there and you pushed it to clean, make it come back. And sometimes it's really hard to bring it back. So I needed to tell you that. Now, about an enema. I thought I had an enema bag. Well, I'll just use this. If you have an enema bag, go on and clamp it and fill it, usually 1,000 milliliters. If it's soap suds, then you can just have soap and put it in it. Warm water, and I know you learned this. I just want to reiterate, so you're great when you get out. Put KY, I beat you to death on KY and Vaseline last week. Put your KY on the tubing. Get them on their left side and open their rectum, their buttocks, and put it in. Hang this up on the IV pole. And you've got your clamp so it's not pouring out. And I go up as far as I can before I can't go any further. When I was in nursing school, they said 1.5 inches. Well, that's just not, I mean, it just goes and water comes right back out. That's not the worst thing because it stimulates. Anytime you're doing anything to the rectum, it's going to stimulate. So that wasn't the worst thing. But I like to go as far as I can so that it will make, it will stimulate high. And so I go as far as I can, as far as it'll go. And so I have this hanging up, and I can control. I always put that fracture bedpan. Remember the fracture bedpan from last week? I put it under the buttocks of the patient, so if he can't hold it, then now I'm going to have to hold this in the rectum, but I can handle the clamp. I use my hemostats to kind of clamp and then let up a little, letting the water in. And see, it's hanging up, and so I can watch the level of the water and then clamp it. And it is one time, and I really do, 1 or 2 students have been with me with an enema. It's quite a thing to see. But it's the only time I use imagery. And I tell them to imagine. Now, nobody's ever hit me. Nobody's ever said that that's the craziest thing, and I think that's awful what you do. For a second, they get their mind off this. And And what I do is I'll say, okay, we're going to rest a minute. What I want you to do, I go there and say, you got to get it out. I can't hold it. And I'll say, well, now listen, I'm not going to put it in right now. What I want you to do is imagine the beach. And you're on the beach, the sun's beaming down, the mist from the salt water is on your face, and your face is a little salty, chalky. For a second, they don't think about their GI flooding. So then they say, I can't think about that right now. And I say, okay, now we're going to do a little more. And so I open the clamp and put a little more. I can't hold it. You're going to have to take it out. And I go on record, I never take it out in the middle of an enema. What I do is I just keep them and stop it, start it, stop it, start it. Imagery. Another imagery I use is the Macy Day Parade. Now, watch the big blown up animals and you see Pluto and you see Mickey Mouse. You know for a second you do that. It's the only time I ever really use imagery. Because for a second they'll do that. I use a third one is a field and you're so hot and thirsty, but you see a shade tree and there's some glasses lined up that are sweating. They're so cold and you're so thirsty. And I do that. So now we're doing pretty good. I've got that 1,000 pretty much in him. Now, are you holding it? No, I'm getting ready to let it out. No, hold it. Now, if they let it out, I, of course, don't scold them. Sometimes I do say, I'm going to kill you if you let it out. But they know I'm teasing. But anyway, you don't give them permission to let go. They'll let go if they can't hold it. But what you do is, even if they say, I'm going to tell you, I'm turning over, I'm not going to let you do it anymore, then what I do is just open wide up and let it flush in and flush right out into my bedpan. In other words, it's done some stimulating rather than just, okay, I'll pull it out and clamp it. Just rush it in, and he's going to let it go in the bedpan anyway, my enema. Okay, now the colostomy I wanted to talk about. And let me say, they're not doing as many, and when they do a colostomy, they're anastomosing pretty quick. I say in a month or so, or 3 months, usually at the most. And so, we still do have them and doing them, but just not quite as much. The stoma, of course, is there, and they may come back to you with a bag on the stoma, and your orders are to just remove it and replace it. And, the bags now have a clamp that you just clamp. And the ostomy nurses are asking that we change them as little as possible. The wafer with the bag fitting, the wafer, the male-female fit. Because they would rather us empty them here and put the clamp back on. Now, your patient, so your job is the wafer, and then the fitting kind of male-female Tupperware kind of fit, and that stays with the clamp on the end, and you just push it out like you would toothpaste and clean the bottom, and then put your clamp back on. We sometimes have to take them off if they're leaking, but the ostomy nurse says the less we pull off the bag, the longer the wafer will stay on, and we don't have to do this ritual as often. I hope you understand what I'm saying. So the bag, the clip. Now, in the past, we would irrigate somebody's colostomy. We're not doing it much now. And I'll have to say, I always wondered why we did it, because nobody's really constipated. I've never known anybody to be constipated in the colostomy. I've seen little pellets, and I've seen loose, but I've never seen where they're constipated. Well, sometimes they want it irrigated. And I'm going to tell you, the tray comes, and it's layered with, you could never have done one, and with just good common sense, you can figure out how to do it. And what you would do is, here's the tray. They came back from surgery with the bag on, but he wants it irrigated. So they're so weak. I may leave them in bed, or I may get them to the bathroom, and I do it all. But let's say that they're at the bathroom sink. One of the first things that is in my tray for irrigation is a bag that's opened at the top like Ziploc with a long, they call it sleeve. This is very long, and it goes between their legs. So it goes on, goes between their legs into the commode, and then this Ziploc top, I'm going to put the enema. That's what it amounts to. I put, it's really an enema, they call it an irrigation. And I put it into the stoma, and then I just irrigate. About 1,000, 1,500, slow. And it comes out and goes into the sleeve, into the commode. Before I even do it, sometimes you're welcome to do it, put your glove on, put KY on, and go into the stoma with your finger, and you kind of see which direction it goes. And you can start with your little finger and go up to the biggest finger, which is your thumb, and it kind of stretches it for when you put your tubing in to irrigate. And like any irrigation, when you're through, like any enema, when you're through, you need to take the tube out, Ziploc it, and let them sit there maybe 45 minutes. You know, any enema, it just stimulates, and you may defecate later. One time, I irrigated a fella, and he was in the hospital not for his colostomy, something else, and I told him, I said, it's a good line, but it's true. I said, Mr. So-and-so, I know how to irrigate a colostomy, because I knew I could figure out. I mean, I've just told you. I said, but I'd like to do it like you do it at home, so I'd rather us do it your way. He said, okay. So he told me exactly what to do. He wanted me to fill the little bag to 1,500. He said, now sit me over there. Let's put it in. And he said, now what I'm going to do, I'm going to put this 1,500 in, and if you'll bring my can of tobacco over there, I'm going to spit in that for about 45 minutes. I'm going to sit here and spit my tobacco and just relax with this. So we got rid of it, and he sat for his 45 minutes because he knew that's how long it took him to stimulate, to put out. And of course it goes into the sleeve, into the commode. Now, I've got one, let me see. Oh yeah, the condom catheters. I just wanted to mention them because I do like them to a certain extent, because it is not invasive. It doesn't stick germs up into the penis. And so they come as a condom catheter. You see it has this end that can be put, attached to our urinary bag. And they simply go on the man's penis just like a condom does. And then you tape, you might want to courtesy tape, onto there. It might stay on its own, but you might courtesy. And the trouble is they can't be too frisky in bed, because in this twist, and when it twists, then it blows up urine over here and pops off. Efficient, they're not the most efficient, but if you had a patient who wasn't moving around much, but he urinates on himself, and then it's not a bad thing, and they don't want the pins on them. So it's not a bad thing. Now, let me see. I want to just make sure I've covered everything I wanted to. Well, I'll never get to teach you everything I want. But, I'm getting there. Remember, one way you can tell dehydrated skin is, does it tint? When you pick it up, does it stay like a tint? They're tinting, then they're dehydrated. Or does it twist like gum and stays in place like it were chewing gum? I don't think you need to chart that. It stays in place like chewing gum. Anyway, now, if you'll just sit here 1 second, I've got one thing to run get I forgot to bring. Okay, I'm back. And some of you have seen it in my office, and you know how I am about baths. And I think I've done everything I want to teach you right here for right now. I've always got stuff. But you're learning and I'm learning. Let's keep on learning and learning and learning. But I really believe, as I told you last week, when somebody's so restless at night and they feel so bad in their greasy sheets, that a good bath makes everybody feel better. And so a student last semester had his mother fix this up for me. Can you read it? It's better than a pill. It's better than a pill, because I would say a bath is better than a pill. Thinking about you, proud of you, do good.